So I think we're gonna start. Thank you all for coming to attend this presentation. So what I'd like to do today is to walk you through a little bit some of the work we did lately on the use of humanized mouse model in order to enhance the translatability of safety and efficacy studies in preclinical models. So this is my disclaimer. I'm a genO employee and I also hold stocks from the companies. So basically, as you all know, one of the main challenge in the field today is really to try to fill the gap between the preclinical and the clinical by trying to enhance. Sorry, I'm just trying to see where to stay. Okay, perfect. By trying to develop models of better quality, models that will better mimic the human situation, and try to reduce the failure rates in the clinic. Looking into the novel strategy which is being developed in the field, it's quite obvious that most of the strategy are acting both on lymphoid and myeloid cells, which mean that a humanized mouse model should be able to have both human, mouse, and myeloid compartment in order to be able to capture the MOA of a given compound, in order to be able to assess its efficacy, but also in order to be able to predict a potential safety issue with this compound. So this is the state of the art of assessment of cytokine release syndrome in a humanized mouse model. Several years ago, Merck published a paper jointly with the FDA where they basically use a model called BLT. I'll get back to this in a few minutes, which was constituted with human PBMC cells. And basically what was shown in this paper is that when those mice were injected with TGN-1412, which is the CD28 superagonist developed by Regeneron, you were able to see a release of TNF-alpha few hours after injection, but also an increase of myeloid cytokines such as IL-8, IL-6, and others, as reported in the clinic. So, in other words, the model reproduces what has been seen with TGN-1412 in the clinic when they had these unfortunate incidents with their compounds. This model called BLT, it's a model which has a human, which is reconstituted with human fetal tissue, has a human bone marrow and human liver. This model works well, but unfortunately, it's not scalable because it is based on the use of fetal tissue, and that has certain ethical limitations. For example, many companies won't accept to work with this type of model, especially if they have subsidiaries in Europe and in Japan, because that creates some ethical issue to use ethical tissue for research purposes. Few times later, another paper was published by a group in Germany, Weissmuller and al. And in this paper, this is basically what they showed. They reconstituted NSG mice with PBMCs this time. And what was observed was the following. TGN-1412 induces the secretion of TNF-alpha and interferon gamma, but no myeloid cytokine were detected, in contrary to what has been seen in the clinic or in contrary to what has been seen in the BLT model. So, in order to try to understand these different cytokine release profiles that has been seen in the different strain, it's really important to try to understand which are the immune cells involved into these models upon reconstitution. In this paper published by AstraZeneca, they look into PBMC reconstituted model. And as you can see on the first graph, you clearly see that upon reconstitution, the majority of the human cell will be human T cells. You have very few human B cells and almost no myeloid cell in a PBMC reconstituted model. In the same paper, they look at the survival of these mice, and as you could see, most of the animals die at 8 weeks of age, okay, due to the GVHDs that develop, with one exception, which is a double knockout mice, which are MHC class 1 and class 2 knockout, where the survival increases up to 20 weeks, with a survival rate of approximately 20%. So, what we decided to do was to try to really see how the immune system of a CD34 constituted mice is different from a PBMC to better understand how to appreciate the cytokine release syndrome that will be seen in the different models. In a paper that we published in 2024, we compared the immune system of mice reconstituted with cord blood cells, CD34, versus mice reconstituted with PBMCs. The PBMC reconstituted mice were assessed 2 weeks post-reconstitution, and the cord blood cell reconstituted mice were assessed at the age of 20 weeks old approximately. First thing you can see is upon CD34 reconstitution on the right, on the left-hand side, you have a diversity of immune cells, including B cell, T cell, NK, myeloid cells, whereas the PBMC reconstitution mainly leads to development of T cell and B cell, as you can see on the right-hand side. Looking now into these T cells, activation status and phenotype, what the analyze tells us is that in a PBMC model, the majority of the T cells are naive T cells, 3% versus 30% the minority are naive T cells, and the memory T cells represent the majority of the cells. Looking now into the activation status of those cells, as you could see here, those cells in the PBMC model are CD25 high and LAG3 high, suggesting that those T cells are becoming pre-activated, most likely due to the GVHD that I just mentioned a few minutes ago. So although you're not seeing clinical sign here, those T cells get pre-activated, and that pre-activation could indeed introduce a strong bias in your analysis. But also, the lack of myeloid cell could be a limiting factor in the analysis that you would perform using such a model. So, AstraZeneca, in the paper that I'm quoting here, decided to compare the cytokine release syndrome induced by OKT3 in NSG mice reconstituted with either PBMC or cord blood cells. As you can see here, when PBMC reconstituted mice are injected with OKT3, so an anti-CD3, you clearly see a secretion of different human cytokines, including IL-2, TNF-alpha, interferon gamma. And these cytokines are detectable at significant level. When the same experiment was performed with NSG reconstituted mice with cord blood cells, they detected only IL-2 in pink, and they detected no TNF-alpha and no interferon gamma, which is quite surprising for a T-cell engager. So, when we analyzed this paper, our conclusion was the following. In the cord blood cell reconstituted NSG mice, we know that we have very few myeloid cells. So the myeloid compartment will be missing in this cytokine release setup that they have developed. And as such, you won't be able to have an activation of the myeloid cells by the interferon gamma and TNF-alpha produced by the T cell upon activation. And the corresponding loop of cytokine secretion will not happen. Hence, the low cytokine detection on the cord blood cell reconstituted mice. So, in order to run a safety assessment of a therapeutic, we would recommend having a model which expresses both lymphoid and myeloid cells. These are the models which are available today. The model the most studies and the most published is the NSG-SGM3. That model is an NSG background and overexpresses 3 human cytokines, SCSF, GM-CSF, and IL-3. It does develop a myeloid compartment on top of the lymphoid compartment. However, it has been reported that those animals develop anemia. They last for approximately 4 months, and they do develop spontaneous inflammation, as you can see here. A second generation of model was developed by Taconic and the CIA in Japan. These mice overexpress again IL-3 and GM-CSF. They no longer express CSF. The human myeloid compartment does develop as well, but what you're seeing here is that although the survival of the model has increased, there are still spontaneous inflammation that develop, and the animal also have a multiple organ failure that could be detected in those mice as they aged. From these 2 models, we concluded that most likely the problem with this was not the myeloid cell development by itself, but was the mean used to develop the myeloid compartment. So in these mice, the myeloid compartment development was supported by a massive supraphysiological overexpression of cytokine, and those cytokine was not being controlled by the endogenous production of human cytokine because they were driven by synthetic promoter such as CMV. So the basic of immunology, which is that cytokines should regulate themselves, doesn't apply here. So we decided to move to something totally different, go in a model which has no T cell, no B cell, no NK like the others, but introduce a knockout in the mouse FLT3 in order to reduce the mouse myeloid compartment. That reduction of the mouse myeloid compartment enabled the development of a niche that would support the development of human cells and development of human myeloid cells more precisely. Upon immune system development, the human myeloid cell could be boosted by transient injection of FLT3 ligand, and that FLT3 ligand will specifically activate the human cell since the mouse FLT3 has been knocked out. That transient induction doesn't create any side effects and support the boosting of the human myeloid compartment. I'll detail this model in a few minutes. The model was started to be presented in 2017, and 6 years later, the JACs and Taconic and the CIA decided to move in the same direction because they did realize the side effect of their model. They decided to generate a FLT3 knockout model as well on an NSG or a knock background to overexpress human FLT3. But again, here they went through an overexpression which is not physiological. And what is reported in the paper published by the group of the CIA in Japan is that although they do see myeloid cells, those myeloid cells decrease at the animal age, most likely due to an exhaustion, due to the supraphysiological delivery of FLT3 ligand. So, to recapitulate, the model has a myeloid compartment. The myeloid compartment is functional. We don't see any side effect related to its development. Another matter of fact, people were quite surprised when we started to talk about this. So Janssen told us whether they could, and they asked us whether they could try these mice because they were using the NOG-EXL and they were seeing a severe body weight loss. They compared the body weight of those mice over 6 months at their site. And as you can see, the BRGSF keep on putting weight while the NOG-EXL show a drastic body weight loss over time. So to recap on this, this is how the model works. It has no T cell, no B cell, no NK, like the others, no difference here. The main difference being that we are not on a SCID background, we are on a RAG2 background. So we are not mutating PRKDC. As such, those animals do not develop spontaneous tumor. The mice are reconstituted as newborn mice. Upon reconstitution, they would start to develop a human immune system. And that human immune system would first be mainly dominated by lymphoid cells. Those lymphoid cells would be present, and upon FLT3 ligand injection, as shown here on the right hand on the slide, where FLT3 is provided 1 injection every 2 days over 4 injections, you start to see a significant increase of the myeloid cell in the FLT3-treated mice, both in terms of cell frequency and cell count. So I told you that the FLT3 knockout resulted into a reduced mouse myeloid compartment. And this would mean that if we have less mouse myeloid cell, we have less background signal due to the contribution of the mouse myeloid cell in the immune response that will be ultimately monitored in those mice. How the mouse myeloid cell look like in the model? So we compared BRGSF mice, which is the background on which the model has been developed, versus BRGSF-HIS mice, which were already reconstituted. And having an analysis focused, having an analysis on mouse CD45 positive cells, you clearly see here the reduction of the mouse CD45 population. That could be seen when gaining on monocytes, on DCs, whatever they are, CDC or PDCs, with one exception, which is the neutrophils, because neutrophils come from a different background, a different lineage, which is not FLT3 ligand dependent, and as such, they don't respond to the FLT3 knockout. Upon FLT3 ligand injection, as you can see, FLT3 ligand has no effect at all on the mouse myeloid cells. It doesn't increase it. The only increase which is seen is in the neutrophil compartment, and this is mainly due to the human cytokines which are being produced by the human myeloid cells that develop, that leads to the progression of those human myeloid cells. So in this model, the T cell compartment shows the standard population of T cell. You find conventional CD4, CD8, Tregs, but you also find gamma delta T cell, which is quite unusual for a cord blood cell reconstituted model. And those gamma delta T cells are functional. We do have data on that. Looking into now the B cell compartment, the B cell compartment again don't show any abnormality. We found pre-pro B, immature B cell, transitional B cell, follicular B cell. Most of the pre-pro B are in the bone marrow. The rest would be detected into the spleen and the bloods. And surprisingly, you know that it has been described in many papers that B cells from these mice are B cells which had a stop in their differentiation, and they don't go over the IgM, IgG stage. When we breed those mice and we just look into their serum, we could detect human Igs of different subclasses, and the class switch goes up to IgA. So the B cells are capable to go into the last stage of the class switch, so they are fully functional. And model has been used a lot in order to assess T-cell engager targeting pathogenic B cell in the context of autoimmune diseases, but I'm not going to talk about this today because we're in a cancer conference. How long the engraftment lasts? In this paper by Labart et al., they look into the engraftment of the human compartment into 3 different tissues: blood, spleen, bone marrow. And that was done over a kinetic of 55 weeks, so a year. And as you can see here, that kinetic show no changes in the frequency and the count of T cells in those mice. So the engraftment lasts at least for a year. That's what we could say. Now, if we look into the different immune cell subpopulation, although the immunization rate stays stable, the immune cell population varies with the age of the mice. Here are mice which were monitored, same animals, same donors, monitored over 31 weeks. If we start to look into the different immune cell subsets, as you can see, we see that the NK and the myeloid compartment remain quite stable over time, whereas the T cell and the B cell compartment shows opposite evolution. The T cell compartment increases up to the age of 20 weeks old, and the B cell compartment decreases and stabilizes at the same time, more or less. This is mainly due to the fact that the T cell compartment, the T cell maturation from the thymus takes more time than the B cell maturation from the bone marrow. So it's better to go for mice around 20 to 25 weeks old for your study, just to have the proper ratio of B and T cells, keeping in mind that they don't show any side effects, so you can work with animals which are around that age. Now, could we use this model to assess safety of therapeutics? The first study that we run was with OKT3, because you know that OKT3 has been studied a lot. It has been one of the main arms of T-cell engagers. And cytokine release has been reported for this antibody, but also depletion of T cells. So we decided to reproduce the AstraZeneca study. Just as a reminder, in that study, in the cord blood cell reconstituted mice, they only show IL-2, no TNF-alpha, no interferon gamma. When we inject OKT3 into the model, we detect IL-2, as you can see, but we also detect TNF-alpha, interferon gamma, and those cytokines start to peak at 6 hours. When those mice are treated with FLT3 ligand, in green now, in order to boost the myeloid compartment, we see the same cytokine being produced with an increase of the myeloid-derived cytokine. So, in summary, the kinetic is the following. We first have a peak of TNF-alpha and IL-2, which shows the T-cell activation. Then we see an increase of IL-1 array, CCL2 and CXL10 that show the myeloid cell contribution to the cytokine release. And ultimately, we start to see 6, 10, and CXL8 that peaks later that clearly show the myeloid cell contribution in the system. What is quite nice is that we're not only seeing cytokine release syndrome means cytokine release and symptoms. And the symptoms are also being seen here, as you could see. Looking into the body weight and the body temperature of those mice, we can see a drop, which is increased when the myeloid compartment is present. So the myeloid compartment contributes to the clinical sign, and both body temperature drop and body weight loss are visible. We see clinical sign, we see cytokine release. Do we have the same type of immune cell activation that has been reported in the clinic? It has been shown in the clinic that OKT3 depletes T cells. So what we decided to do was to investigate the immune cells in the OKT3 treated mice. And what we observed was the following one. 2 days after OKT3 injection, we detected a depletion of the T cell compartment in the animal treated with the OKT3 in red and green. But we also detected a decrease in PDC, CDCs, and monocyte, which is most likely due to an exhaustion of those cells. In order to show that the cytokine release that we're seeing here, it's really due to the human immune system and not to the mouse trauma that is around, we decided to treat the mice with an anti-human TNF-alpha in order to really show that if we block TNF-alpha of human origin, that would have an impact on the cytokine release development. This is what was done in this study. And as you can see, the infliximab-treated mice, which is an anti-human TNF-alpha that doesn't cross-react with mouse TNF-alpha, infliximab-treated mice in orange shows a mitigated cytokine release, but also show an impact on the body, on the clinical sign that were observed into the OKT3-treated mice. So we can manage the cytokine release using standard means such as, for example, infliximab or tocilizumab, although tocilizumab is less reproducible. So this was a good finding, but it was important to us to show that what we're seeing is not therapeutic dependence. So we decided to move to a second therapeutics, which is on the market now. So Blincyto is an anti-CD3, CD19. It is commercialized. It has been reported few cases of cytokine release, but they can be managed, and they are pretty transient at the first hours after Blincyto injection into patient. So we basically followed exactly the same protocol, injection of Blincyto, and we monitored the cytokine release. As you may remember, with OKT3, cytokine release was optimal at 6 hours post-injection. Here, it's much earlier, 2 hours post-injection, and the nature of the cytokine we're seeing is no longer the same. So we have a compound which is in the clinic. We do see a peak, but that peak goes down rapidly, hence the lack of toxicity of this compound in human in the clinical trial. Looking into the clinical sign, we don't see any body weight loss with this compound. We do see a slight body temperature drop, again, which come back to normal, suggesting that this compound is much less toxic than OKT3 that we presented previously. We did the same thing. We looked into the T cell activation, and as you could see here, we were able to show an increase of T cell markers such as CD25, PD1, and LAG3. And that was indeed in line with what was reported in the clinical trial with Blincyto, where people have shown an increase of T cell activation marker such as CD69, CD25, and HLA-DR+. So we decided then to go for therapeutics which are not T cell, which are not targeting T cell. So we decided to go for therapeutic targeting myeloid cells. Several years ago, Janssen came up with a first-in-class anti-VISTA, which went into clinic, and that antibody has an early stop due to strong toxicity. So what we did was to take the anti-VISTA of Janssen and try it in the mice. We use as a control OKT3 as a positive control. As you can see here, the cytokine release induced by the anti-VISTA is much stronger than the one induced by OKT3. Having a look at the immune cell population, we basically discover that, this anti-VISTA was depleting the VISTA positive cells. VISTA is mainly expressed on CD14 positive cells and DCs. And as you can see, at 48 hours, you see a total wipeout of your CD14 positive population and a decrease of your PDCs. We were working with a novel anti-VISTA that worked in a pH selective manner. And that anti-VISTA was at its preclinical assessment. So he didn't went into clinic yet. We tested it into this model against the Janssen anti-VISTA. And as you can see, when we injected the SNS-101 developed by Sensei Therapeutics, we had no cytokine release at all into those mice. And looking into the VISTA-positive population, it was still present. It was no longer depleted. So it's not VISTA by itself that triggers this. It's a type of therapeutic that has been developed that triggers this. Then we decided with that anti-VISTA to test its efficacy in our VISTA knock-in mice. So safety in the humanized model, efficacy in the knock-in mice. And Sensei was able to show that in combination with an anti-PD-1 in red, the antibody protected against melanoma progression when compared to PD-1 alone in the dark blue. The anti-VISTA from Sensei went into clinic then. They were able to show that the SNS-101 has an acceptable risk-benefit profile and could be dosed 10 times higher than the Janssen anti-VISTA. Then they started to dose the antibody in human, multiple injection, and as you can see, after multiple dosing, you see no effect at all on interferon gamma, IL-6, IL-10, IL-8, and TNF-alpha, as predicted from our in vivo study in the humanized model. So for the first time, we were able to show that what we have in the model correlates what was obtained later on in the clinic. So in the data I've shared so far, I'm showing you one injection, but I just showed you that the standard protocol in the clinic is to go by multiple dosing, as Sensei Therapeutics did. So we decided to see whether this could be assessed in the model and if this would show changes in cytokine secretion. So we decided to reproduce the protocol that was used for Blincyto in the clinic. So mice were treated first with Blincyto. As you can see, after a few hours, 2 hours, and 6 hours, we see an increase of 6, 10, and interferon gamma. But we also detected IL-1 array, CXL2, and CXL10, although these cytokines were not monitored into the clinic. When we did the second round of injection, we detected a much milder cytokines release, as reported in the clinical trial one more time. So, again, we said, okay, let's go now with different type of therapeutics, which are depleting agent. We decided to investigate rituximab effect into the model. As you know, rituximab targets B cells and targets CD20 more precisely. First thing that we did was to show that the compound was showing efficacy into the system. So we injected rituximab into the animal, and we checked for B cell depletion in the blood and in the spleen. And as you could see here, 48 hours after rituximab injection, we do see a significant decrease of the B cell population, which are seen here by CD19. And this could also be seen at 24 hours. We look into the kinetic of depletion, and what we observe is after 14 days, you start to see a relapse of the B cell coming out from the bone marrow in this system. Looking now into the population that was targeted by rituximab, we find out it was mainly transitional mature B cell, which are IgM, IgD positive. So rituximab could show activity in the model. What about cytokine release now? We decided to test rituximab as reported in their clinical trial. So we first did an injection, look at the cytokine release few hours after injection, 2 hours, 4 hours, 24 hours, 48 hours, and 96 hours. And this is basically what we observed, a peak of IL-6 and IL-1 array. The scales are different among the graph, okay? Hence the different curves. But what was most interesting is that when those animals received a second dosing, we start to see that the same cytokine were peaking again. So you can really recall this after multiple dosing and reproduce the human clinical design. Here, we don't see with rituximab any clinical sign, which is what we were expected because that compound is indeed on the markets. So it has been reported that fructuzumab has a different safety profile in healthy patients and in tumor-bearing patients. And that increase of cytokine release is most likely associated with what is known as tumor lysis syndrome, TLS. So the next step would be to compare the cytokine release induced by therapeutics in naive mice versus tumor-bearing mice. But before doing that, what was important to us is to make sure that the targeted population from these therapeutics would be recruited at the time of tumor development, would be polarized, would be activated as they should be. Otherwise, it won't make sense to do this in tumor-bearing mice. So we decided to investigate the TME composition of BRGSF-HIS mice and grafted by different tumor types to see how the tumor drives the immune cell recruitment, but also drives their activation and polarization. In the paper that I'm quoting here, we basically engrafted mice with different tumors: breast cancer, pancreatic cancer, lung cancer, and colorectal cancer. First take-home message is that the tumors by itself drive the immune cell recruitment at the site of tumor development. In red, you have the human CD45 cell. In mouse, you have the mouse CD45 cells. And I wanted to show you this to show you that all tumor models are not the same. HCT16 recruits mainly mouse CD45 cells and very few human CD45 cells, whereas the first model recruits mainly human CD45 cells. Now, looking into those immune cells, we see that in the MDA system, the majority of them would be myeloid cells. In the HPAF, the majority of the human cells are T cells. In the A549, we have a mix of T and NK cells. So NK cells are present, although IL-15 was not supplemented. I insist on this because you've heard a lot that IL-15 is needed to get NK cell. It's totally model dependent. And finally, in HCT16, you have a mix of T cell and NK cell, including NKT cells. So NK cells are in red, NKT cells are in Bordeaux, and you have the T cell in blue. So the tumor origin, the tumor type would basically triggers immune cell recruitment and immune cell polarization. Now, having a focus on a myeloid cell-rich model, this is what we can see. In the MDA, so in the breast cancer tumor model, where the majority of the immune cell in tumor around 400 cubic millimeters are myeloid cells, you have most of those myeloid cells which are monocytes. You can see that this is quite consistent across donor because each dot is one donor. Those monocytes are polarized toward M2-like macrophages. They are activated as shown by CD80, CD86 expression level. And they also express immune receptors such as LILRB1, LILRB2 involved into escape mechanism to the immune response. Now, looking into those M2-like macrophages, they are all PD-L1 positive. But the PD-L1 MFI increases as the tumor burden increases into the animals. So you clearly see the dynamic of the interaction between the immune system and the tumor. And we also found into this TME gamma delta T cell, which get polarized as well, delta 1, delta 2, delta 3, and get activated as shown here by CD107A as an activation marker. So different immune cells get recruited, activated, polarized. In order to better look at the activation of T cells and NK cells, we decided to go into different tumor models which are more prone to recruit T cell in the TME. And for that, we basically looked into the lung tumor model, A549. That model shows a recruitment of immune cell which increases up till the tumor reach 500 cubic millimeters, and then the human cells start to decrease, and we have more mouse cells coming into the TME. Again here, you're seeing a recruitment first of NK cell in red and T cell in blue. And at the end, when the tumor is around 800 cubic millimeter, you have mainly NKT, and myeloid cells that are present. This is the kinetic of recruitment of the different populations I just mentioned over time. Now, those NK cells are recruited. Do they get polarized? We decided to perform a clustering of NK cells based on their activation markers, and we were able to identify some NK1 cells, which are the cytotoxic NK cells, based on those activation markers. That population evolves with the tumor burden, and we also identified NK2 and NK3. So the NK1, as I said, are the cytotoxic NK cells. The NK2 are the chemokine secreting population, whereas the NK3 are the adaptive NK cells, and you clearly see how they evolve with the tumor burden. What about now the T cell in this tumor model? We decided to look into the Treg because we were interested in trying to modulate their activity. We identified two subsets of Treg, non-activated and activated, based on expression of GARP, Ki67 and TIM3. And what we showed here was that on top of these two populations, we also have a population called iTreg, which is involved into tumor tolerance that develop, and these are the cells which are CD27 positive. So again, the Tregs get recruited, get polarized, and do show exhaustion markers as well. Last point is the NK. In a different tumor model, this time in the HCT16 colorectal cancer, you are clearly seeing that in this model, you have mainly T and NK cells. The NK population, which is shown in reds, evolve over time, and you're getting more NKT being produced, and you also have more T cells being recruited. And having a look into these NK cells, looking into a marker such as NKG2A, which is a marker of, which is an inhibitory receptor, we clearly see that it increases as the tumor grows, whereas activating receptors such as NKG2D decreases as the tumor grows, suggesting that those NK cells are being recruited, have an escape mechanisms in front of them, and become exhausted over time, hence the loss in the activation mark. Okay, so could immunotherapy induce anti-tumor response into those mice? We basically here tested different types of therapeutics, and I'm not gonna go too much into detail. I'm just gonna show you some snapshot of those. First, T-cell engager. When we decided to work on T-cell engager, the question that we had was, this was a few years ago, would a engagement of signal 1, which is CD3, or engagement of signal 1 and 2, which is CD28 and CD3, provide a better cytotoxic response in vivo? So in this study developed with light chain, these guys had antibody targeting CAA, CKM5. So we used a model of pancreatic tumor, and mice received different treatment. Treatment with a bispecific targeting CD3 CAA. And it's known that CD3 CAA has very few effect on pancreatic tumor development. This is what you're seeing in red here. Or combination of the double targeting of T cell via signal 1 and signal 2, CD3 CAA, CD28 CAA. And in fact, the signal 1 and 2 provided jointly to the T cell resulted into a synergistic activity and showed a better control of the tumor growth and a better survival of the mice. Based on this, they decided to test different combination therapies. And in the same pancreatic tumor model, mice were treated with a CAA CD3 alone, or in combination with a CD28 PD-L1 bispecific antibody. And again here, we observed that the combination of the combo therapy providing a signal on CD3 and CD28 via PD-L1 targeting provide a much greater control of the tumor growth in blue versus the control groups. We also tested drug targeting the myeloid compartment. I cannot disclose the target here, but there's a target expressed on myeloid cells. And this was targeted using an ADC. And as you can see, the ADC treatment resulted into a significant control of the tumor outgrowth, as shown by the pink curve in this graph. Finally, we also tested therapeutic approaches aiming at repolarizing the monocytes. Ligor-B's receptors are inhibitory receptors, which triggers an inhibitory signal that blocks the NK cell activation. Macomix developed a pan-Ligor-B antibody, which binds to the Ligor-B's receptors and turns their signal into an immuno-activating signal instead of an immuno-inhibiting signal. And that results into activation of NK cells. And as you can see here, using this antibody, we clearly see the control of the tumor outgrowth in this model of A375 tumor model. So, last example is to try to repolarize the T cell response this time. Teva developed an anti-PD-1, which is a non-blocking anti-PD-1. So that antibody would bind to cells that are PD-1 high, so exhausted T cells, and that antibody is coupled to an attenuated IL-2. And that attenuated IL-2 should reactivate those cells and turn those cells into CTL. The antibody was tested into a melanoma model into those mice, and versus nivolumab, so versus anti-PD-1. And this is what was observed. The nivolumab treatment is shown in dark green, in light green, and the Teva compound is in dark green. This poster was presented at the SITC in 2024, and they had to basically bring the result at that time, so they only looked at 15 days post inoculation. But the study went further, okay? And the study showed indeed much greater difference between PD-1 and their compound. But at this stage, at day 15, what we're seeing is we do see a slight control of the tumor outgrowth, but more importantly, looking into the TME, we clearly see here a significant changes in the polarization of the T cells with a significant change in the CD8 effector memory T cell Treg ratio in the TME. So repolarization does work into the system. As in any humanized model, you have to deal with something that one would say it's reassuring because it shows that the model is relevant, and one would say it's a pain because we don't know how to handle it, which is donor variability. In those models, you have two types of variability: intra-donor variability and inter-donor variability. That variability is totally therapeutic dependent. So there's no golden rule to say what to do. And I'm just going to show you here a few examples. In the light chain study on the T cell engagers, we had 4 donors enrolled. Out of those 4 donors, you clearly see that 2 donors in the middle responded well, 2 donors responded poorly. If you decide to target checkpoint inhibitor using PD-1, it's even worse, to be honest. This is a study with an anti-PD-1. You don't see any effects. If you break it down per donor, we had 6 donors here. You see that the donor 4 does show an effect, but the other don't. If you do the math, you have between 15 to 20% of the donors that respond, as it is in the clinic. So we are just reproducing what has been seen and what has been reported for years and years, which is reassuring about the quality of the model, but which is also not so convenient to deal with when you have to design a study, because you have to enroll a lot of donors for PD-1 targeting, and this is really PD-1 specific. With the ADC studies that I showed, this is the data that I showed you a few minutes ago. If I break it down per donor, I don't see any donor effect here, because here it's a cytotoxic payload that you're delivering. It's no longer an activation of the immune system that does the work. So it's totally therapeutic dependent. And if we don't understand what type of therapeutic you're working with, we don't know how, we won't be able to advise you on how to design the study. So just to conclude on this, what I've tried to share with you today was that it was possible to do efficacy and safety in the same model in order to be able to correlate a therapeutic effect, a therapeutic index, and a safety profile. This could be done using models which have both lymphoid and myeloid cells, and the presence of myeloid cells is key in this system, otherwise you won't see the clinical sign. We've been able to show that in retrospective study, we were able to reproduce what has been seen into the clinic, both in terms of cytokine release and clinical sign. But we also show that in a prospective study, a compound tested into the model that shows no toxicity, show into the clinic no toxicity as well. The model, it's clear that the safety study has to be conducted not only in naive mice, as most of the people are doing, but also under pathophysiological condition, which could be tumor-bearing mice, model having an inflammatory disease that developed, because the immune system status at that time would totally change the nature of the cytokine release that will occur. And of course, this will also be therapeutic dependent. So where are we moving now with this? What is next in our strategy? We are now developing a preclinical platform to assess safety of profile. And in order to do this, we have tested different therapeutics. I'm not expecting you to go into that busy slide. The only take-home message here is that whatever is green show same result in mouse and human. Okay? And the goal here is to test different types of therapeutics, targeting T cells, targeting myeloid cells, but also CAR T, small molecule. And for that, we are building a preemptive consortium with different partners with the objective to at least test 50 different therapeutics, targeting different types of cells, different therapeutic modalities, and try to correlate their data in the model to what has been seen into the clinic. We're going to take compound that fails into clinic and compound that pass into clinic and see whether this is something that could have been anticipated into the model. We're not going to focus on cytokine release only. We're going to also look into clinical sign, organ-related toxicity, omics approaches, with the objective to really try to assess different types of therapeutic modalities and ultimately try to see if the model could be either predictive to non-human primates or to human. Okay? So this is basically where we're moving next. And just want to hand up here by thank you to all my colleagues that participated into the work that has been presented, but also my colleagues that help us here in having this event being organized at the ACR meeting. Thank you for your time and thank you for your attention. If you have any question, I'll be glad to answer. Yes, sir? Do we have data with leukemia engraftment? Yes, we tested different type of PDX coming from patient, okay? And we compared the engraftment into this model to other immunocompromised model. And to make a long story short, what the study shows was that the model is either as permissive as the other or more permissive, which makes sense because we have less myeloid cells compared to the others, okay? And that resulted in two types of tumor growth curve. Either we needed less PDX cells to achieve the same type of tumor growth or more reproducible tumor growth in the studies. I haven't included this today here, but yes, we did. Did we look at the immune activation in AML context? So we did it. We, in fact, tested some T-cell engager in that context, okay? T-cell targeting T and B cells. And we have seen efficacy, and we have seen ability to control tumor growth. I have to admit that most of the study we do are with solid tumor, okay? Dealing with liquid tumor, it's a little bit more tricky, okay? But it works. Yes, sir? Which kind of triple negative breast cancer model did we use other than MDA MB231? It was the only one that we used. It is the only one that we used. Would grow into those mice? Yes. And I'm not sure. No, BT474 is not a triple negative. No. So it's the only one we used. Yeah. we tested different breast cancer model, but they were not triple negative, okay? And we also implanted those mice with bulbous tumor model, okay? And what we observe, and this, I know that this could be quite disturbing, is if you engraft the mice with bulbous tumor model, they grow as well. And to my standpoint, the explanation is the following one. I told you that we do reconstitution on newborn mice and not in young adults like everybody does. We have been able to show with the team that we do see in the thymus human cells. So upon reconstitution with newborn animal, the thymus will be colonized, but the thymus will have two types of APCs, human APCs and mouse APCs. And both would be able to present antigen to the T cells, hence the lack of GVHDs that we're seeing and why we're keeping those mice for 1 year without any problem. So then there's two possibilities. The immune cells are not functional, but I've showed you activation, or the model is tolerant to both mouse and human antigen, which is most likely the case, but which doesn't match with the handbooks of T cell education. And that could be an issue indeed into certain vaccination approaches, okay? We are trying vaccination, we've seen responses, but we see a lot of variability. Any other question? Yes, go ahead, sir. Okay, the next question was, what about the NK cell activation? So, in naive mice, in those mice, you have very few NK cells, 3 to 4%. But upon challenge, upon stimulus, okay, which is here was a tumor cell engraftment, we see that the NK cell proliferate and differentiates. We have tried some NK cell engager in naive mice. These were compounds that were targeting B cells. Those compounds were not able to work into mouse cells, so they do not cross-react with the mouse CD16. When we tested those compounds into the model, we have seen a depletion of the B cells. And when we tested a version of the compound that is FC null, we're no longer seeing depletion. And so the compound was a compound that has a CD20 and KP46 and CD16 FC. Yeah. All good? Thanks for your time.